We're so excited to have everybody here tonight. It means so much to us in our practice and to the Breathe Institute. We're very excited that we're here in Dallas to be with us. And I'll pass it over to you.
Yeah, so as Carla was saying, we're so excited the Breathe Institute is here. Our office knows that we've been waiting for this. We've called it the event and we've been preparing for it, and we're just so excited about it. We're so honored. Dr. Zaghi is here, and we feel like we're learning from the very, very best and from the entire Breathe Institute team. So without further ado, here's Dr. Zaghi, and he is going to present to us tonight.
Welcome everyone. It's so great to be here with you. Just to show of hands, who here has heard us speak on these topics at least once before? Show of hands in the audience. Fantastic. Welcome back. It's so great to be here with you guys. This lecture is called Sleep, Breathing, Tongue Tie, and Maxillofacial Development, and I really like it. Let's just make sure. No. Let's see what's in there. Because it really brings the community together. A show of hands, how many people here are dentists in the audience? Dentists, welcome. It's great to have you here. Any medical doctors? Medical doctors, welcome. Any dental hygienists, myofunctional therapists, speech therapists? Excellent. Look at this. Any body professionals? Wonderful, welcome. And any community members, any parents, community members, lay people? My name is Dr. Soroush Zaghi. I'm a graduate of Harvard Medical School, UCLA ENT residency, and Stanford Sleep Surgery Fellowship. And perhaps the greatest honor I have is to be medical director of the Breathe Institute, where we provide patient care, research, and education from a multidisciplinary perspective. So the idea is that experts come from different disciplines, each contributing so we can see the problem as a whole. And our mission is to improve pediatric and adult sleep and breathing disorders. In the course of the next hour and a half, we're going to show you how simple things early on can make a big difference, not only in the prevention, but also the definitive treatment of our kids with obstructive sleep disorder breathing. And the question comes up, why breathing? Why the Breathe Institute? And if you think about it, the truth is that breath is life. And if you breathe well, you will live long on earth. Do you guys agree? Everybody keep our lecture interactive. Absolutely, right? Breath is life. Think about that. Without breath, there is no life. While breath is life, and breathing is simple, it's actually also a little complex. And it turns out that what we learned in medical school, half of that material is true, and half changes every 5 years. This is the slide, the first slide the Dean of Harvard Medical School put for us. And he said, half of what you'll learn in medical school, or dental hygiene school, or speech therapy school will be shown to be either dead wrong or out of date within 5 years of graduation. The trouble is that nobody can tell you which half, so the most important thing is to learn how to learn on your own. Who here agrees with that statement? Show of hands. Who here agrees that we have to continually learn and improve? Who here agrees? Okay? And the way that we do that, how do we do that? We do that through research, right? You go to school looking for answers, and then when you graduate, you research for those answers. You research for that truth. And that's what we have doing. I can't believe it. It's now 6 or 7 years that we've had the Breathe Institute. I graduated from fellowship, and we're constantly learning. So if you haven't heard me speak in the last 1 or 2 years, you're going to see a lot of new content emerge. And we're so proud of that. Yet, as I'm here before you guys to lecture, I want to let you guys know the huge team behind the scenes in our office, as well as in the community at large, who is actively contributing to advance the research in this arena. Today, we're here to start the discussion on these topics by a simple thing called tongue tie, ankyloblastia. Who here has heard of ankyloblastia in some form? Who here has never heard of it? Anyone? You guys are part of the audience. We had a conference call where the partners were like, I've never heard of that topic. And he learned something, and he gave a referral to get one of his nieces or nephews to come get evaluated. So even if you've heard of it, even if you know what a tongue tie is, I'm asking you guys to take a different look. Are you guys with me? Are you guys open to seeing things from a little bit different perspective? And to do that, let me introduce you to my son, Maxim. Here's Maxim at 19 months. He's sitting and he's running, right? Pretty simple, but also complex acts, right? What I love skiing. Any skiers in the room? Anyone might love to ski? I love to ski. And how amazing when you go out to the ski events and you see little kids, 3, 4, 5, 6 years old skiing. Have you guys seen this? I dream that one day I can take Maxim skiing with me. Yet, am I just going to put on some skis and push him down the slopes? No! You have to take things step by step, and you have to continually keep him on track. So the first goal is just to expose him to these ideas. Expose him to the cold weather, to the snow. Have him walk on it, right? Before you run or you ski down. And here he is, I'm guiding him. Yet he goes off track. Do you guys see that? And so our job as parents and uncles and aunts and community members is to keep our kids on track. And as complex as skiing is, how complex is chewing and swallowing? Right? When it goes right, it's very simple. But when it goes wrong, it's actually quite complex. Speech therapist in the room, right? Good to see you. Kind of complex, right? To teach your kids how to chew and swallow. And here's Maxim eating foods of different consistencies. And we imagine the difference it makes when you chew versus slurp your food. When you chew your food, you're actually growing and developing the face. Notice that he's chewing and swallowing as he's breathing through the nose. Now, Maxim, when he was born, all right, he had excellent APGAR scores. So the pediatricians evaluated him in terms of his appearance, pulse, grimace, activity, how he's breathing. And he got APGAR scores of 9 and 10.5 minutes. Thank goodness, right? And we're so grateful to the medical doctors who are there to put out the emergencies, put out the fire. And what do you think I look for as the first thing? What's the first thing I look for? I looked at his tongue, right? I looked at his tongue, and sure enough, his tongue was connected to the floor of the mouth, right? His tongue was physically tethered to the floor of the mouth. His tongue was tied to the floor of the mouth in such a way that it's impacting the function. So really the question is how can we avoid going off track? We're going to start the discussion with tongue tie and tongue posture. Yet we realize that there are a host of issues that can affect our loved ones. Do you guys want to see maybe Maxim's tongue tie release?
Yeah. Yes.
You want to see it? All right, let's see. A long 12 seconds, right? Long 12 seconds. But amazing what a small intervention can do. Here you see the tongue physically tethered down to the left. There he is at 5 days old, 3 days post-op, with the tongue not down, but up. And there he is at 8 days, with the tongue fully high up in the roof of the mouth. And so the question we ask is, what if we didn't release him? What if he persisted with this tongue tie? What kind of things could we expect? Speech, swallowing, chewing, oral hygiene, breathing, and even posture. These concepts with tongue tie are far from new. Here's a woodblock of a physician performing a frenectomy in 1679. Wow, 400 years. Here are the instruments they use, and a lot of them are actually very similar to the instruments we use today. Yet, with the advent of evidence-based medicine, we need evidence, right? We need randomized, double-blinded, placebo-controlled trials, right? With the advent of evidence-based medicine, there's a push for more evidence. Yet we consider that the way to get a double-blinded, randomized controlled trial, is that possible for surgery? Can you blind a patient? Can you blind someone to surgery? Are you going to randomize these kids to see who gets the intervention and who doesn't? So we recognize that it's really only pharmaceutical interventions that can meet the standards of evidence-based medicine, and the vast majority of the evidence that supports dentistry, orthodontics, even ENT surgery are case series and case reports when a community comes together to shed new light on topics. Yet unfortunately, what we are seeing is an epidemic of just watch and wait. And here is one of our patients from the Breathe Institute, in which the pediatrician took a look at this, and what does the pediatrician say? You don't need, he's fine. Right? He's fine. For a tongue tie, is that right? Yeah. Go ahead and open your mouth for me. And try 7 times again. Okay? Alright, no worries at all. So we talked about the fact that your tongue tie is contributing to your speech, is that right?
Yeah.
Tell me about it.
Like, I feel that when I speak, I can't alliterate as clearly as I want to, and also when I'm trying to talk quickly, I can't really speak as quick, or else I get tripped up.
Gotcha. And then we also talked about swallowing. Sometimes when you have a banana, you tell me about that.
It's like when you eat like a certain type of food, you just start to gag sometimes, and it's like an awkward feeling, I guess.
Totally. We talked about your posture, is that right?
Yeah.
And then tell me when you're sleeping, what happens with your mouth?
When I'm sleeping, my mouth like unintentionally opens up when I'm sleeping, and it just happens, I guess.
Gotcha. Totally. And so we were talking earlier that this was identified earlier. What did they tell you?
As long as he is tongue his eating habits and is able to speak, that enables a function that doesn't have to be taken care of.
Gotcha. Well, thanks for coming here, and I'll take care of you. How amazing is that, right? They look at this and they say that as long as it's not causing any problems, he's telling us he's gagging, he's choking, his forward head posture, mouth falls open. Yet, to add fuel to the fire, the ENT Academy, the American Academy of Otolaryngology Head and Neck Surgery, came out with a consensus statement. Now, a consensus statement is not high-level research. A consensus statement is you get a bunch of ENTs in the room and you ask them, does tongue tie affect speech? And I'll ask you guys, what do you guys think? What's your opinion? Do you guys think tongue tie affects your ability to make speech? What do you guys think? Yes. You know what the ENT doctor said? They said no. They said apical velocity does not affect speech. You don't have to move your tongue in order to produce speech. Why? Because it's not in our textbooks. I went to this medical school and that medical school, and I did this board and I did that board, and I'm the surgeon. And it's not in any of my books, therefore it's not true. Right? That's what we're up against. And so this is an example of confirmation bias. When you think you know it all, that's when you don't know. Okay? The only people who really know are those who leave room to continue learning. Is that right? Because the truth is always changing. We're constantly researching for that truth. So we always have to keep a little bit of an open mind in order to benefit as well as to produce high-level research. And that's what we're doing here at the Breed Institute. I myself am an author of 80 peer-reviewed publications, and as my postdoctoral fellow, after Harvard, after UCLA, after Stanford, I got interested in tongue-tie. What do you think my mentors told me? Go ahead, you're wasting your time. I had my mentors call me and say, Soroush, you had so much potential. What are you doing? We trained you to be a surgeon. What are you doing with these little tongue-tie surgeries? Yet, as we did the research, and as we're growing the community, and as we now have 2,500 ambassadors throughout the world, as we now have almost 40 affiliate sites, and we're welcoming Gloria here tonight. We stand tall and proud in our quest for the truth. And the thing with the truth is that you search for it, but you never actually find it. It's the process of searching for the truth that we strive for. And that's what research is. Research is systematic investigation. It's the investigation, it's not the endpoint. And in order for us to have high quality research, it has to go through a systematic process with various stages that each article that we publish takes 3 to 5 years from the thought to the conception. And what happens if we just skip over it? What happens if a research paper where I say, what do you guys think? What happens? Well, you can see that even if you have such a good idea and such a good introduction, if you skip over the methodology, the results are less than desirable. Would you guys agree? And we have to make sure that we overcome bias, not only confirmation bias, but also measurement bias. Measurement bias means how we measure what is a tongue tie and what is not. There's a lot of problems with that. Doctors will say, that's not even a tongue tie. Well, we're measuring it differently. As well as performance bias, such that the procedure we are doing is very different than the procedure the ENT doctors are saying doesn't work. You guys follow me? And here's an article that was published to suggest, does tongue tie play a role in speech? Okay? And the article shows 3 columns: tongue tie children, untreated tongue tie, and treated tongue tie is the first one, untreated tongue tie is the middle column, and not treated tongue tie is the last one. And they measured the speech, okay? And so the treated tongue tie have a speech score of about 9.29. Right? And the untreated had 8.29, right? So you would think that the treated tongue tie, the study would show, would do better, right? They had higher numbers. You know what the conclusion was? Do you know what the conclusion was? It was that, I'll read it. This study provides preliminary evidence of no difference between tongue mobility and speech outcomes. How is that? They had higher scores, yes, but it wasn't statistically significant. And it turns out the sample size was so low that no matter what results you got, it would never have been statistically significant. What kind of research did they do here? Lack of evidence is not evidence. Just because you're not able to achieve statistical significance because you rushed the study and you weren't patient enough to follow enough patients, that's not evidence. So when someone presents this article to you and says, yes, but there was a consensus statement, what I'd like you guys to say is yes. But there are a few ENT doctors in something called the Breed Institute, with its affiliates and ambassadors, who do have experience treating these things, who do know how to identify the tongue ties, who do know how to treat them. And we actually published a rebuttal letter to the editor specifically with this point. The point being that we need to listen to our patients. We need to get our heads out of the books and look and see and ask questions. Because that is the basis of good clinical research. It starts with observations. The observations start with you in the community. With those observations, we strive to establish new facts. Let's take a look at this girl we treated at the Breed Institute. It's an adorable girl with difficulty with heart.
Because there was an and camp group. On Wednesdays it's everyone, and there can't be too many people, and not enough desks. Airplane. Ferry. Fair. Only. Stall. Earphones. Cereal. Deal. Ear.
Pretty good.
The gray circle is in the top row left. The brown circle is in the middle row left. The red circle is in the bottom row left. The orange circle is in the top row center. The green circle is in the middle row center. The pink circle is in the bottom row center. The yellow circle is in the top row right.
Amazing. What have we done for this little girl? Not only in her ability to pronounce the letter R, but her confidence, her ability to make friends, her ability to project herself in the world. We've unleashed her potential. And we recognize that it's not just the surgery. You need to have good therapy, good speech therapy in this case. And if you ask any speech therapist, do you need to use the tongue to produce speech? In their textbooks that will show you that yes, you need to lift the tongue to produce those T, L, and D sounds, the front of the tongue, and you need to lift the back of the tongue to make those R, S, K, G sounds. Just try it out kind of quietly to yourself and see how that works. Of course you need to use your tongue to produce speech. The other doctors are not listening. They're saying just do nothing. It's impossible. I've tried it. It doesn't work. What do we say? We say when you listen to your patients and you come from things from multidisciplinary perspective, just do it. Nothing is impossible. And so here is my postdoctoral thesis that we published out of the Breed Institute with my partner Sanda. Stand up, Sanda. Yeah, here we go. I finished fellowship, and I thought I was going to do sleep endoscopy and turbinate reduction, and Sanda pulled me aside. Well, what about tongue tie? Yeah, I can do tongue ties. And we got more and more interested, and so we did 350 cases, and we started to see really, really, really amazing results. Let me share that with you.
It was like everything in my head and back opened up. And so now you can see that the way that I hold myself is completely different. This would have been impossible before the surgery. The pressure in my jaw is gone. The pressure in the back of my head is gone. My Dowager's thumb, which I had a really big one, gone in 1 second flat.
After the first couple releases, I felt this sensation kind of go up the side of my face, just kind of like a release. And then I don't feel like I'm crunched forward anymore. I feel like I can just kind of relax now. I just don't feel as tense. It was really weird. I felt it actually go down my back a little bit. And I feel good.
My quads feel disturbed, and my disturbed feels different. I also feel disturbed feels like it's moved.
When we started the procedure, my feet just sort of naturally had that. The right one was more or less vertical, but the left sit down to the side. And when the first release happened, there was a wave of relaxation going through my body, and my left leg just very naturally on its own tipped up its being paralyzed, and then just really sort of new natural. That make good? Up. Swallow. I'm gonna put pressure in your mouth. Is that okay?
Yeah, it's awesome.
Good. Great. So I want to continue. Is that okay?
Yeah.
It just released all the stiffness
All the stiffness where?
in my muscles and bones and body.
Can you point to it where you felt the release?
Here is good.
Uh-huh.
And down our body size.
Better?
Yeah, we like something just got the release and like, well, my muscle just come down at something everything just operating down.
Wow, right? Wow. When an adult tells you it's one thing, but when a kid tells you,
That's true.
it's just like how could he know? So it wasn't just 1, 2, 3, 4. The first time we saw this, we thought, it's kind of crazy, right? Like, what are they saying? Your foot, and your neck, and like your shoulders. Yet when you see this again and again and again, that's where research comes from. So we researched and we learned that yes, when you treat these patients, they come back telling us that they have less neck and shoulder tension through effects on the fascia system, that they're clenching and grinding less, and that they're breathing better. Their diaphragm is breathing better, their nasal breathing more, and it's truly incredible. Not to mention, of course, the speech and swallow issues. So this was the first article that really showed the huge potential. And so since that point, we've had the privilege of sharing this technique with our colleagues. And others, including Dr. Baxter, have replicated our findings. Yet others have suggested that these procedures still don't work. This was published just a few months ago. Tongue tiredness still doesn't work for speech. So we asked, how could that be? How is it that we're getting these results, but the other doctors are not seeing it? And the truth is that once a week or once every 2 weeks, I get emails like this. This is a patient with a grade 4 to the tip tongue tie that went to a local Kaiser, where the doctor just numbed her up, just went for it, she started to bleed, and you can see how uncomfortable this might be, is that right? This is the procedure that they're doing. Very different than the one that we're doing. And so here she is with an open wound and a lot of pain. She goes to the emergency department. What do they say? It's normal, it's okay. Good. Up your tongue. Okay. Up your down. Good. And you want to tell us anything about your symptoms? Or?
I'm in pain all the time. Eating, speaking, yawning, hurts it.
No, before you got released or right now?
No, right now. So
Right now.
I had a surgery done 10 days ago.
Right.
The hole never closed and I got a white lump above it.
Yeah.
Went to the emergency room and told me nothing. They're like, oh, you're fine.
And so one of our colleagues thank you here, we're so happy with you.
Yes, definitely. Yeah, thank you.
All right. So our affiliates and ambassadors, is this how we perform the surgery? No, right? No. So we release her. Let's take a look. Did we revise it?
Right.
So what we have done is not a frenectomy. What we are doing is a functional frenuloplasty. Functional frenuloplasty, according to our research article, and is taught by the Great Institute to our affiliates and ambassadors. It's a whole different concept that incorporates myofunctional therapy before and after these procedures, and also recognizes the work of physical therapy and other modalities of body work. And so I get these emails once a week, once every 2 weeks, all over the world, which is why we have established our affiliate centers, so that we can expand our impact. And it turns out that actually our first affiliate center was right here with Tad Morgan. Closely followed by Dr. Al Stewart. And today we are here to welcome Loria Nahades. And so what we are here to do is to empower the community with local leaders who are going to contribute to further research. We meet and Dr. Lori and Carla have already been contributing to research ideas to kind of pull these things forward. I had the privilege of being in your office today, where we got to take care of some patients together, including this child. What do you guys think? Is he tongue-tied? No symptoms, right? Just watch it. What do you think the pediatrician said? Exactly that. Yet we see that at the very least, this is affecting his facial growth and development. He's only chewing on one side because you need to move the tongue over, right? You need to use the tongue to move the food bolus over. This is affecting his posture. And when you only chew on one side, when your teeth only come into contact on one side, you get asymmetrical facial growth. This affects you left to right, and it also pulls you forward. You get the forward head posture. You sleep on your side with your mouth down and your tongue low. So what did we do? Did we leave it alone or did we treat it today? What do you guys think? We treated it. There we go. So this is what we got. Let's hear from the mom.
Thank you so much for allowing us to help take care of your little one. You had a great fourth tongue tie. What did the pediatrician say?
Leave it alone.
Oh my goodness. And so what do the doctors here advise you?
I said have you do it.
Okay. Amazing affiliates here. Tag team. Tell us your name. Alright. Go ahead and take off your headphones. Go ahead and open up your mouth for me. Good. Lift up your tongue. Beautiful. Beautiful. Let's get a mirror here. Let's get a mirror. Very good. How does it feel? Good. What does the experience like? Is it easy? A little easy. Take a look here. Hold the mirror here for him. Very good. Look at that. Do you see the difference? Do you like it? All right. Very good. Congratulations. Say hi, doctors.
Is his therapist here? No. Okay. And then he continues on. He's prepared with therapy, and he'll continue on with therapy. These grade 4 tongue ties are technically challenging, so they tag team this case between Dr. Carla and Loria, because sometimes when it's so tight, like the tongue's in your way. So you really have to expose it. And what a beautiful job you guys did together as partners on this case. Yeah? Yet there are other cases where the diagnosis may be elusive. And that is why we have provided extensive training. Dr. Loria has studied with us in the brief course not once, but twice. She's participated through research programs, came and shadowed me for 3 days in my clinic, watched like 20 surgeries over my shoulder, and we are now here to observe and further build so that we can certify her and to culminate her affiliation. So now we have these cases where you can ask yourself, is it tongue-tied? Is it not tongue-tied? Should we do something? Should we not do something? And so really, for these advanced cases, we have to take a closer look, and this is what our training entails. Not only the obvious ones, but the gray area. And so we do a facial comparison, and we see that yes, She too has some facial asymmetry. One side of the face is growing differently than the other. And in the course of the next 45 minutes, we're going to explore some of these concepts. And what a beautiful surgery you did today to help this patient. And we're so excited for all the patients in your community. Yet it's not only about the surgery. What else is important?
Therapy.
What else is important? The therapy. The therapy. So we also are proud of our Mayo Mastermind students. Please stand up, Lori Inglis and Kimberly Wright. And I'll tell you that our Mayo Mastermind training is even more challenging than affiliation. Okay? They're not only licensed expert speech therapists, dental hygienists, am I right? Yeah. Okay? Yet they also took upon themselves lots of continuing education just to qualify for the Mayo Mastermind program at Sonda. Stand up, Sonda, right here. Yeah. To really push these protocols forward. So our Mayo Masterminds and our affiliates are there to support our local ambassadors. Ambassadors, raise your hands. Ambassadors who taken my course. Okay, fantastic. Welcome, welcome. All right. We want these protocols in every dental office, in every school. We want to empower everybody, and our affiliates and our Mayo Masterminds are here to support you. All right. So, you guys feeling inspired? Yeah. You guys interested to learn more?
Yeah.
Should we learn a little bit more? What do you guys think?
Yeah.
Should we talk about the role of tongue tie and the effect it has? We understand speech and swallow, right? We're good with that? We're going to put that to rest? Okay? What I really want to talk to you guys about is what the tongue has to do with breathing. Should I talk about that for a minute? What do you guys think?
Yes.
Okay, speech and swallow, it makes sense. You have to move your tongue to do speech, right? And to swallow, right? Okay? But for breathing, Dr. Zaghi, right? Anyone have that question? Anyone want to ask it? Raise your hand if you have that question. Anyone want to research? Yeah, right? It's interesting, right? Let's see, what does the tongue have to do with breathing? The tongue has everything to do with breathing. Okay? Breathing through the nose requires two things in 100% of people everywhere. The first thing is that you need to have a patent nasal passage. We have about 100 people here. Amazing turnout. Thank you guys so much for being here. Let's do a study with 100 patients. Are you guys with me? Plug your nose and try to breathe. Can you breathe? No! You must have a patent nasal passage in order to breathe. Are you guys with me? Yes? Yet you also need the back of the tongue to come up to direct that airflow in and out of the nose in order to have good nasal breathing. The tongue is the on-off switch for nasal breathing. Are you guys with me on that? When the tongue is up, the switch is turned on. The air will go in and out of the nose. The only way to mouth breathe, there's no other way to mouth breathe, than to have the tongue in a low position. Let's try that experiment here together. Go ahead and click your tongue to the roof of the mouth. And breathe. You'll notice that if you're making a nice complete seal, the air is going in and out of your nose. Now try to breathe through your mouth. The tongue comes down. You guys notice that? The tongue is integral to nasal breathing. Have I convinced you? When you have the tongue tied, is the tongue being held high or low? Low. And when the tongue is low, you're going to do mouth breathing. And in order to breathe through the nose, you have to require more effort. You have increased respiratory effort. You have to try harder to get the back of the tongue up. And the beautiful thing about these concepts is once you see it, you can't unsee it, right? So, are you guys ready for your pop quiz? Pop quiz, all right? Is this child mouth breathing or nose breathing? Nose breathing. The switch is on. The air is going in and out through the nose. How about this child? Mouth breathing. Mouth breathing. The switch is off. The air is coming out through the mouth. Very simple principles. Are you guys with me? You want the tongue to rest high in the roof of the mouth. When the tongue is low, it's dysfunctional. And the dysfunction is not only for speech, swallow, and breathing, but also development of the face. When the tongue is high, the tongue is going to put pressure to help the jaws go wide and forward. Yet when the tongue is down, you're going to get vertical growth. The face is going to grow long and narrow. When the tongue is up, it makes a negative suction cup effect such that the tongue stays up throughout the night. Here's a child that we released. You can see his tongue is high. Are you seeing that? The tongue is up in the sleeping tongue posture hold. It's breathing through his nose. There's no other way. The switch is firmly on and up. What a beautiful result. Sometimes it's going to be firmly down, and other times it's going to be firmly up. Yet the area that we need expertise is for these borderline cases. Maxim was not borderline. He clearly was stuck down, and afterwards he's clearly up. Yet there are other patients who have low tongue posture, like this child, related not to tongue tie, but to problems with torticollis. Anybody professionals in the audience here who treat torticollis? You guys treat torticollis? Amazing, amazing, amazing. So this child has a tightness in the extraoral fascia that pulls on the intraoral fascia and pulls the tongue down, not because of tongue tie, but due to the muscle tension. And can this be treated? Is it treated in surgery? No. We need to take a multidisciplinary approach to tongue tying and tongue tie space. Are you guys with me? So pediatrician says what? It's normal. Mouth breathing is normal, right? Mom knows it's not normal. So what do? We observe, and we observe, and we watch the smoke turn into a fire. Yet she's not going to sleep upright. Now she's going to sleep down to get the tongue out of her airway. But she's sleeping on her face. Do you guys notice that? What kind of impact does sleeping on your face, twisting your septum, have to do with your growth and development? Do you think her nose is going to grow straight? Or do you think it's going to grow crooked and to the side? What do you guys think? And how is that going to affect her nose breathing? Make it even worse. Okay? Oh, poor lady. Poor lady. So here we watch how a low tongue posture leads to mouth breathing, leads to noisy breathing, leads to snoring, leads to sleep apnea. And yes, now the tonsils are enlarged, and we remove the tonsils, yet we recognize that that's just tip of the iceberg, right? There's so much left underneath. And what we're here to say is that sleep disordered breathing is on a spectrum that starts with mouth breathing, leads to noisy breathing, snoring, and then sleep apnea. You don't just wake up one day with sleep apnea, right? There are root causes. And in a functional approach to sleep and breathing, in a functional approach, we're looking for those root causes. And one of the root causes is tongue tie. Other root causes are problems with chewing and swallowing and posture. And some kids are even born with high arch palates. And once you have a problem, you enter the cycle of dysfunction. And our job is to help these kids not only not fall into the cycle of dysfunction by keeping them on track, but by getting them out in a multidisciplinary perspective. Recent studies show that it's not just about sleep apnea. Sleep apnea affects 1 to 2% of the population. Problems with noisy breathing and snoring may affect the 25% of the population. Mouth breathing, noisy breathing, and snoring. And you consider with mask wearing, how are our kids breathing? They're hyperventilating with their mouths open and their tongues low and their lips apart. And recent studies show that mouth breathing, snoring, and noisy breathing without sleep apnea changes the shape of the brain. It diminishes the cortical gray matter and makes them behave from more of a brainstem place. This is what underlies children's ADHD, aggression, emotional regulation, among other issues. So here we have Dr. Guillemino, who was my mentor, and Dr. Guillemino was against mouth breathing. In 2014, he published this revolutionary article that said that we should strive for nasal breathing. And he was at first met with resistance, and now we accept that. And Dr. Kim, described that there's something that causes the mouth breathing. He doesn't know what it is. It could be inflammation, it could be posture maladition, it could be abnormal. He didn't quite know, but he knew that once you were mouth breathing, that was a bad thing. Because the mouth breathing would introduce local inflammation inside the mouth, that would lead to large tonsils and adenoids, and further perpetuate the high arch palate and abnormal oral facial growth. Our Institute of the Breathe Institute characterized that tongue tie sometimes, among other causes, low tongue posture. Okay? And it's that low tongue posture, that dysfunction that underlies the abnormal oral facial growth that leads to mouth breathing and sleep disorder breathing. So now what we have is this cycle of oral dysfunction. When the tongue is high, it's going to help develop the jaws wide. When the tongue is low, you're going to miss out on that. You're going to miss out on that expansive force. Yet you're also going to have altered diet, altered chewing. You're going to chew more with the front rather than the back. And this is going to affect the way that the teeth develop. And more important than the teeth is the arches that support those teeth, the maxillomandibular arches. And so if the arches are narrow, it looks like there's too much teeth in this mouth. But the dental crowding is just a sign of the problem. It's not the problem. The problem is that there's not enough space in the mouth for the teeth or the tongue. Faces grow long, and you can clearly see these issues. Not only inside their mouth, but also at the level of their eyes. Here's a child before and after treatment published in this article reference, and you can see the lateral canthus of the eye is lower than the medial canthus. You can also see his under eye grooves, and sometimes there are other features as well, including rolled shoulders forward head posture, and other findings that we discussed. So you can take a look at this individual, just at his eyes, and I ask you, what do you think his jaws look like? He's narrow and underdeveloped. The lateral canthus is lower than the medial canthus. And so we recognize that when you have low tongue position, you're going to have a high arch palate. The roof of the mouth is the floor of the nose. Think about that. The roof of the mouth is the floor of the nose. If your mouth is small, your nose is going to be small. You're not going to have enough room in your nose for that deviated septum. The mouth breathing is going to contribute to further turbinate hypertrophy. Yet in addition, the roof of the maxilla is the floor of the orbit. And so you have depressions of the inferior orbital rim and the zygoma. We described these things back in 2017 and demonstrated that yes, tongue tie is related to development, but it only accounts for about 7.6 of the problem. The vast majority of cases also involve alterations to tongue posture, chewing, swallowing, diet, mouth breathing habits, genetic factors, and other things. So if we're trying to send a lifeline, we have to recognize that surgery is only one piece of the puzzle. The real hard work comes with the therapy. And that's how we're going to get our kids out of the cycle of obstructive sleep disorder breathing, where they start with mild forms and they progress to more severe forms as they have diminished cortical arousability. Yet it's not just about upper airway resistance syndrome or even sleep apnea. These findings are apparent even at the level of the teeth. And so that's why we encourage the pediatric dentist to go beyond just a pediatric dental exam, right? You want to go beyond just typical pediatric dentistry. That's what it's about though, right? That was the vision, isn't it? That's the whole point. That's why they call it beyond pediatric dentistry. It wasn't an accident. So we have shown that in children who grind their teeth, these kids are going to have tongue ties sometimes, nasal obstruction, tonsil hypertrophy, and we published on this through UCLA, showing that if you have tongue tie, difficulty with the nose and tonsils, almost 100% of the time, you're going to have clenching and grinding of dental wear. Yet if you have none of those factors, it's still possible, but much less likely. So my question to you in the audience is, when you're evaluating your patients, is it important to assess tongue posture? Yes or no? Yes. All right. For your second question of your final exam, can tongue tie sometimes cause low tongue posture? Yes, it's sometimes, it's not always. Is tongue tie the only cause of low tongue posture? No. Okay? We have to consider problems with tongue tie, but also his two friends. You know who his two friends are? Who knows? Tongue tone. That torticollis is good. Torticollis will go to tongue tone and tongue space. Okay? I love that. Here's a more extensive differential diagnosis and an article that references that. So we're no longer just talking about tongue tie, we're talking about functional ankyloglossia. And functional ankyloglossia is anything that functions like ankyloglossia. So that little girl with the torticollis has functional ankyloglossia. Functional ankyloglossia is first treated with therapy or motor therapy, body work, physical therapy, and then reevaluated to determine the need and readiness for a release. And then followed up with more therapy. You guys getting it? That is a functional approach to frenuloplasty. The function comes before the frenuloplasty. Functional frenuloplasty. We recognize the problem of mouth breathing can cause these problems, muscle tone, poor posture, and we have the field of myofunctional therapy to help us restore these issues. There is a whole host of research that now supports this, but I don't want to bore you with the research. I'm going to show you a patient. Here's a 2 years, 5-month girl with sleep disorder breathing. So what do? We cut out the tonsils, do we cut out the tongue? No. We get her into therapy.
Up, comes up, you got there. 1, 2, 3, hold up there. 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Clean it up! Clean up!
It seems simple, but it's actually quite complex. Before this child would even allow her, you're tearing up, that's beautiful. It's beautiful. Before this, it really strikes a chord with a lot of us. These issues are very common. Very common. Who here has someone in their family affected by these issues? Show of hands? Absolutely. Right? And so what we recognize is that these kids aren't even lunching with their mouth, they have oral aversion. Their shoulders are up to kind of protect the back of the throat because the tongue can't do that function. So first you have to desensitize, and the therapy starts in the hands, and the feet, and the posture. Sometimes with occupational therapy before you can even get inside the mouth. So what you're seeing here is an incredible feat. It probably took several months just to get there. When things are right, they're simple. When they're not, it can be quite complex, right? So that's why we're so proud of our Breathe Babies and Kids department. We're making a bigger effort to incorporate pediatric dentists, okay? Here's my wife, Dr. Nora, Dr. Anna Gross, getting a PhD in speech language pathology, and Dr. Pinto. So Dr. Pinto released Maxim's tongue tie, but is he done? Is that it? He's gonna have perfect life, perfect posture, everything? No, we have to keep him on track with good feeding and chewing and swallowing, and it starts before it starts. It starts at birth. So as a parent, I'm a first-time parent, I didn't know what to feed my kid, right? You go to the grocery store, you say, where's the baby food? And they give you baby food, right? No! Did you guys know that? How are we supposed to know that? That you're not supposed to give baby food to babies. When you give baby food, when you scoop it into their mouth, it develops, promotes a tongue thrust. You want them to develop a healthy relationship with food. You want them to be in control. You want to give them different consistencies, and you want to graduate those consistencies. And so we did baby-led weaning. I didn't know what that was. Baby-led what? So here he is developing a healthy relationship with food, feeding himself, tongue goes up. Okay? And are we done? We gotta keep him on track, right? But Maxim made a bad friend. He made friends with the family dog. And here is how he learned to eat. Oh, Maxim. He's so proud of himself too, right? He's like, look at me. So if Maxim can learn from the family dog, can he learn from you and me? Are they watching what you do? Are they going to learn from their siblings? Wow, right? Did you guys think about that? Pretty incredible. Here is something I thought I would never see. Maxim at 14 months, eating whole pieces of steak. Incredible, right? Okay, whole pieces of steak, grasping it, chewing in the back. And it's really that chewing and swallowing action that we need. Not only for the nutrition that it provides, but for the actual chewing function. Have you guys seen these little tablets that are like fruits and vegetables? Get all your vegetables in a pill? Have you guys seen this? Alright? It's not the pill. It's the chewing and the swallowing that we have to strive for. Your kids are watching you. They're trying to fill your shoes in. And a great opportunity to educate them. Because chewing and swallowing does the body good. But in order to chew and swallow, you have to have the right instruments. And they have to be in working order. And to that extent, leave the tongue up, lips closed, and healthy breathing through the nose. Yet, if there is a problem with a tongue tie, we can see how the tongue tie is going to interfere with the function. Here's a child who has noisy lips apart mouth breathing. And here she is just a few days later. Beautiful. So in a functional approach to ankyloglossia, we want to first establish nasal breathing, restore optimal function. Where are my therapists in the audience here? Where's my therapist? Raise your hand or stand up even. You guys are doing the heavy lifting, all right? Stand up there, stand up. I think I can go get you. Get up, let's go, let's do it. Keep up, all right? So we understand now what tongue tie has to do with sleep disorder breathing. It also affects posture. When you have a tongue tie, it's pulling your head forward and down through the connection to the fascial system. Here's a patient immediately before and after the release. Okay? The tongue is connected to the rest of the body through a system of connective tissue known as fascia. The fascia literally connects from the tongue to the diaphragm, to the psoas, all the way down to the feet. And when you're tight, a little bit of a release can do a lot to open up this fascia system. Right, so let's now talk about the 5 dimensions of tongue tie diagnosis. How do you know if you have a tongue tie? Most pediatricians are using something that was published in 1999, over 20 years ago, such that you have to stick out your tongue 16 millimeters. Can you stick out your tongue 16 millimeters with the Kotler 3-tongue measurement? And we recognize that there are a lot of people who can stick out their tongue, like this one, but can't lift up the tongue. And so we have this gentleman with severe sleep apnea. He could stick out his tongue, but rather we need to have him lift up his tongue. Lift up not only the front of the tongue, but also, more importantly, the back of the tongue. So in 2017, we characterized the tongue range of motion ratio to characterize the anterior mobility of the tongue. What do you think happened 5 years later? We outdated this, and we now have published in 2021 the lingual palatal suction, characterizing that, yeah, the front of the tongue is important. It's important to stick out your tongue. It's important to be able to lift up your tongue, not only the front, but also the back of the tongue. And so here is a patient before and after, much improved. Yet there are a lot of patients in this gray zone, where they're able to lift up the tongue, but they do so at the expense of the floor of mouth and the neck. We call this a compensation, right? They're compensating. They're not lifting up the tongue. They're pushing up the tongue. Take a look at this girl. We ask her to lift up the tongue. What does she do? She uses her neck, her floor of mouth, her whole face. No wonder she's having headaches and neck and shoulder tension. So we are now going to be publishing in the next year the floor of mouth hold maneuver, in which we put one finger on the floor of mouth and watch as the tongue comes up. This has been shown to be highly correlated with development of posterior crossbite. Let's take a look at how we can do that.
And just to kind of contrast, lift up your tongue, lift up the tongue to the front of your teeth. Okay. So you can see that it looks like a grade 2 tongue mobility, but really she's bringing up her entire floor of the mouth. And if we hold her floor of mouth down, where it should be, and ask her to lift up, you can see she can't get it up. She just cannot get up her tongue. You see the dimple right here that reflects the side of the frenulum attachment point.
So everyone, you guys see that?
Yeah.
We're going a little fast here, okay? Here's Jen, our amazing director of operations. Stand up.
And a tongue model.
Yes, thank you, Jen. Going to demonstrate good function here for us.
So again, go ahead and open your mouth as wide as you can without fear or discomfort. All right, now lift up your tongue up to the front of your teeth. Very good. Now suction up for me. I'll show you your cage. Excellent. We don't really see any compensations here, but if we want to control for them, we can use this group director. And so go ahead and open up your mouth. And I'm just holding down the floor of the mouth here and noticing that it's not restricting the mobility of the tongue. Very, very good. Show me your cage. Okay, and again, it's not.
All right. So let's take a look at this case. This individual is trying to get up the tongue. But do you see how much she's trying? Do you see how tight that band is? So we do the floor of mouth hold maneuver, and this is what we see. All right. And so here he was before and after the release. Before, his tongue was down. You guys see how the back of the tongue is down? Immediately after, the back of the tongue comes up. Just like the videos, just like the diagrams that we see. The back of the tongue down, this is up. What we want are for the tongues to stay up, high in the roof of the mouth, without tension, without pulling. And this is how we train our providers. This was a very cursory look at the 5 dimensions of tongue tie. Just want to kind of leave it in the sense that there's a lot more to learn on these topics. I do want to spend a minute on one other very, very important area. We've talked about tongue tone, we've talked about tongue tie, and now I'd like to take a few minutes to talk about tongue space. Anyone hear about tongue space? Okay, amazing. This is a term that we coined and we're promoting more and more to reflect the need for there to be enough room in the mouth for the tongue. And we are also collecting data to publish in the Functional Tongue Space Classification, where we have the patient suction up their tongue once they've learned to do so through the therapy, and to assess whether or not they have overflow. Does that tongue fit in that mouth? In this example, you can see that it fits nicely. In this one, you can see that they're struggling a little bit, in the sense that it's passing the mid-maxillary roof or coming completely outside the dentition. Are there signs of scalloping? And so we take a look at this case. What do you guys think? Does that tongue fit in that mouth? No. If you're ever unsure, we advocate for a cone beam CT scan, but not just taken by any protocol, rather the Breathe Institute protocol. And so we had 5 affiliate centers. Dr. Stewart was among them, who contributed to data, who took 20 patients and scanned them twice in different postures. And we learned that the way you take the CT scan really matters, such that when the head is up, the airway is open. When the head is down, the airway is closed. And a little bit of a tilt can make a big difference. Here, the head is slightly down, about 6 millimeters, slightly up 1.1 centimeters, and more so in this case. So the question I have to you is, how much do you think you have to change your head posture to affect a 25% change in the airway space? Any guesses? Any guesses? Turns out it's only about 5 degrees. A 5-degree change in head posture can account for a 25% difference in the posterior airway space. That's why the heads are going forward on these kids and trying to open up their airways. A 10-degree change results in an 88% difference. Is this valuable research? What do you guys think? This is the work that we're doing at the Breathe Institute with our affiliates and ambassadors. So we have cases like this with the bite registration and chin rest, and our research article will also talk about the impact of chin rest, sitting versus standing, among other variables that we use to develop this most optimal protocol. Using this protocol, we're always looking at tongue tie, tongue tone, and tongue space. Here's a patient with a severe tongue tie who has enough tongue space. This patient is going to be predicted to do very well from the procedure. By contrast, here we have a case where the patient, despite a forward head posture, only has about a 2 millimeter airway. We advocate that this patient is not a good candidate. The tongue tie may have been the root cause, but at this point, there are other factors that need to be considered, including making more space in the mouth for the tongue. If you release this tongue, the tongue can swell up and further block the breathing. When in doubt, you want to do a scanner according to the right protocol, which is possible through our affiliates and our ambassadors, okay? What we want at the Breathe Institute is to take a functional approach where we're addressing the root cause of these issues. We want to figure out what is underlying it. We want to identify the smoke before the fire. Who's here with me? Round of applause if you want to do the smoke before the fire. In a functional approach to sleep and breathing, we recognize that it's very, very simple, but also complex, right? We're not talking about crazy medicines and enrichment. We're talking about chewing, swallowing, posture. These things are simple. And really, it all begins with good breathing. Breathing is the beginning. The nose plays a fundamental role in protecting us from nasal immunity. When you mouth breathe, you're bypassing that nasal immunity. The mouth breathing changes the saliva inside the mouth. It dries it out. It changes the oral microbiome, making you more prone to problems like gingivitis, as well as tonsil hypertrophy. The mouth breathing changes the shape of your nose and your face. It alters the way that you chew and swallow. Here's a little girl with sleep disorder breathing. She can't breathe. Do you think she's going to prefer chewy foods, hard foods, or soft foods? Soft foods, because the mouth breathing diminishes chewing efficiency. So here's this little girl with cyclical wall dysfunction, and we recognize the big impact these issues can have. I'm going to briefly share with you my case. Really, breathing is the beginning, and I personally struggled with this for quite some time. So I'm now 2 weeks post-op, just 2 weeks post-op from a sinus surgery and septoplasty. I actually was a patient with an anterior open bite, and I graduated from Harvard Medical School. I graduated from UCLA residency and Stanford Sleep Surgery Fellowship, not knowing that I was a mouth breather and that I had a tongue thrust and I had all these issues. And so here I am now. It's been quite a journey. I've had many, many different people help me with this. It all started when I got hit in the face with a basketball. I got a deviated septum. I'll show you guys here. It's my nose. You guys are really getting to know me, huh? Right, so I had a deviated. It wasn't that bad, but it was just enough to bother me. I had chronic headache from my sinus issues. All right, turbinate congestion, allergies, pretty bad, right? Here's my CT scan. I just have this mucus that wouldn't drain. So it was a little bit of I had a big surgery, but it was well worth it. This is me immediately after, a day or two later. Here I am 1 week post-op. My befores and afters, I'm so happy I did it. It was 2 weeks out, so I'm still a little congested. yet the mucus isn't sitting in my sinuses anymore, it's coming out my nose. And it turns out, inside the nose, you have this little thing called cilia. Have you guys heard of it? And the job of the cilia is to beat the mucus backwards. Okay? Now, I just had a nasal surgery, and they operated my turbinates, so my cilia aren't working well. So I have to use gravity to have it go back, or I have to sniffle, and it's just part of the recovery. Yet surgery is only one way that you can injure the cilia inside your nose. Can someone else tell me another way that you might get problems with your cilia? Go ahead. A cold. Right? You have a cold, you get a virus. The cilia get inflamed, they get injured, they don't function well. How long does it take the cilia to regenerate? It can take up to 2 months. Wow. So these kids with chronic inflammation in their mouth and nose, what should we do to help them breathe better? What do you guys think? Should we jump to surgery or should we try the thing? Just had a cold.
Clean their nose.
What's that?
Clean their nose.
Clean your nose.
Nasal
Clean your
hygiene.
nose. Absolutely. All right. And let me just show you this 1 second here. That's not it. Okay. So this was me, first of all. Okay. Here we go. Do you guys know who this is?
Gloria! Woohoo!
I'm Dr. Gloria here, and I just wanted to show everybody, actually, we have our single patient named Alice. Alice, how old are you? She's 5.5. She's going to show us how we clear our nose. So first what we do is we blow our nose to clear it out. And then we will use some saline spray. This is called Clear, and it's a xylitol spray. And we just spray about half. Inhale in one side, and then about half a spray in the other side. And then she starts inhaling and exhaling only her nose. She's holding her lips closed while she's doing this. And she holds her breath for a few seconds after she exhales. And what that does is it builds up nitric oxide in the paranasal sinuses. And what nitric oxide does is it helps with oxygenation for your whole body. So it's really good to do this. So this is part of our nighttime hygiene. We brush our teeth, we floss, we wash our face, and we clear our nose to make sure that we're breathing through our nose while we're sleeping. Because if we're not breathing through our nose, we're breathing through our mouths, and we all know that's not good. So here we go. She's done this a few times. We do it about 10 times, and then she blows out. Oh, this extra yucky stuff that comes out, right? Yeah. And how is that? Nice and clear? So she started doing this when she was about 4 years old. Anyone can do it, and I really encourage it. Thanks so much for watching.
Amazing, amazing. Lead by example. Round of applause. Doctors who really understand the cycle of oral dysfunction, who know that it starts with the function, yet also reserve the place for surgery when indicated. Here's a 12-year-old boy who had a very, almost since birth was a mouth breather because he had a very badly deviated septum. Current dogma suggests that you have to wait until you're 18 or 19 in order to do nasal surgery. Yet here's this child with a very severely deviated septum before and after surgery with me. And this is the same child just 1 to 2 months later. This child started nasal breathing and grew 4 inches because of the release of growth hormone with nasal breathing and deep sleep. Amazing, right? Amazing what we can do with a multidisciplinary collaborative approach. So who here feels inspired? Who here wants to get in here? Yes. Amazing. Amazing. So the question is that, yes, do you guys agree? We want all patients to breathe well, yes? Woo! Yeah. We want all patients to sleep well and function well through prevention, early identification, management, and definitive resolution. Yet we also understand that there are not enough medical doctors and ENTs to take care of this problem. There are only 10,000 EMTs in the country, and maybe 1,000, 2,000 in the country who deal with kids. Think about that. These EMT doctors are there to put out the fire. We need you guys in the community to find and put out the smoke. Who here's with me? So the question is, again, what sleep and breathing tools can we use? And so there are questionnaires that we provide. Yet as concerning as it is when a parent says yes to all these, you know what's more concerning? When the parent of this child says no to all these. That's even more heartbreaking, right? So what are we gonna do when the parents don't see the issue? So through the Brain Institute, it took us probably 5 years, with Dr. Christian Guilleminault himself being the conceiving thought leader in this area, to develop the FAIR 6. You guys have this handout here with you? You guys have this amazing handout? All right. So the great thing about the Breathe Institute, is chat here? No? The great thing about the Breathe Institute is that we not only produce high-level research, but we're also here to deliver it and execute it in a way that's approachable and easy to understand. Okay? Here are 6 factors that you can look for that are completely objective. It does not require any input from the parent. All you have to do is to take a look and assess. And our research shows that there are 6 potential red flags, each building on the next. And it all begins with breathing. Nasal breathing versus mouth breathing. Observing for mentalis strain. This is something that I think every school teacher should know. Every teacher who's counseling parents about ADHD and putting them on medicines should incorporate a FAIR 6 questionnaire. Everybody, everywhere. Determining whether or not these kids are at risk of a sleep and breathing issue that may be the root cause of why they're not sleeping well, why they're feeling fight or flight, why they're feeling aggressive. And the mentalis strain is a sign of vertical growth, mandibular deficiency, lip incompetence, among other issues. You want to look for tonsil hypertrophy. Of course, tongue tie. Not only the front of the tongue, but also the back of the tongue. Dental wear, and the narrow palate. Who here likes this questionnaire and might use it? Who here thinks the questionnaire is better than just a paper that's just text? Yes? Let's give a round of applause to Chad for putting this together. As well as Lily and Jen, our managing director and partner, who really is a spearhead for all these ideas of innovation. So this is now part of the AAPD, American Academy of Pediatric Dentistry. It's been published in Journal of Dentistry, and it's going to be taught to all pediatric dentists everywhere. On their boards, this is going to be on their boards. How incredible is that?
So great. Yes.
Amazing. Round of applause. And from there, for adults, we can do home sleep studies and home CT scans. For kids, we're no longer advocating for in-lab sleep studies. We're primarily, focusing on video camera sleep screenings. You don't need to hook them up to a wire in a foreign environment to see these kids struggle. And these videos are more powerful than a report. They're also potentially more accurate, because this report, depending on who interprets it, may be normal mouth breathing. Is this normal? Far from it. And so we catch these things early, we're in good shape. But look at this girl. All right, she takes a breath, and then we count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. Oh my goodness. That's sleep apnea. The other child doesn't have sleep apnea yet. It's upper air resistance, moving around side to side, cortisol, parasympathetic tone. We're here to tell you that if you identify these issues early, when it's just mouth breathing and noisy breathing, you can get them into therapy, get some clearing exercises, and have a profound, profound difference. These issues start early. Everyone who has sleep apnea started with the root cause. Here is one of our Breathe Baby affiliates, Dr. Calleros. And we see that one side of her face is growing optimally, the other side is not. We're now better able to understand why she has a deviated septum on this side. We asked for a baby picture, and we recognized that she had cranial strains that affected her vision. And when your vision is affected due to torsion of the cranial strains, you hold your head at a slight tilt. Now go ahead and just put your head to the side a little bit and see where your teeth touch. So you're going to touch more on that side. Go to the other side. This is going to affect the way that your face develops. This is going to affect the way that you chew, the way you hold yourself. The whole body is connected. What a concept. A change in one area is going to affect problems in other areas. So we ask, when did things go off track? Here is a beautiful, talented, very intelligent violin player. She played the violin 8 hours a day for 10 years. Okay? 8 hours a week for 10 years, okay? What posture do you take when you play the violin? All right. What's that going to do to your posture growth and development? Incredible, right? Wow. Wow. No wonder she has a twisted spine. No wonder she has TMJ clicking and popping issues. We're here to identify the smoke before the fire. That's what we're about at the Breathe Institute. I hope you guys enjoyed this very brief lecture. This lecture is intended to inspire you and to inspire your thirst for continuing education and more knowledge in this arena. We at the Breathe Institute provide continuing education courses for providers of all backgrounds. We even have resources for community members. And really, we're here to spread the word that really breathing is the beginning. And I hope that you guys will join us in our courses and we'll give you more information on that. But really what I want you guys to appreciate is that the mind, once stretched by a new idea, never returns to its original dimensions. And so I ask you, will you join us in bringing better breathing to your communities? Thank you guys. Really an honor to be here in front of you guys here today. When we first started the Breathe Institute, it wasn't easy. I was promised a job at UCLA as faculty. I applied, I went to Stanford, did everything I was supposed to do, and I came and I'm ready for my job, and I gave a presentation, and what a warm reception you guys gave to me. Because the chairman of my department took one look at me, and he said, He said, what you're asking to do is way too radical. We just want you to come here, take out the tonsils, remove the adenoids, do the turbinates. We're not so interested. And I was devastated. Think about that, right? I trained in fellowship for this problem. I was lost. I didn't know what to do. I went to a conference and I just gave out my business cards. Just put it out. Just open, right? At a conference, maybe not dissimilar to this one. Here is your opportunity if you want to get involved, to hand out your business card, to make connections with other people. And we have an amazing central hub here, as well as in our other 2 affiliate locations, so that you guys can get involved. And I was lucky, I went to a conference, and my last business card, I gave it to Sanda. And Sanda gave it to Laylee, our managing director, and together the 3 of us started the Breathe Institute in 2017.
We opened it.
Open 2017. I mean, clenching and grinding. Oh, man. And so we had our first affiliate partnership 4 years ago. And we trained many others. And so this is is probably one of the biggest, most enthusiastic audience I've received, so I really thank you guys from the bottom of my heart.
Because it's Texas, guys.